Welcome to Pediatric Case Review. I am Dr. Abdelaziz Yousef, and today we will be discussing Tetralogy of Fallot, one of the most common cyanotic congenital heart defects encountered in pediatric practice. This lecture aims to provide practicing pediatricians with a comprehensive but practical approach to diagnosis, management, and long-term follow-up of children with Tetralogy of Fallot. Let's begin our clinical journey through this important cardiac condition. Let's begin with our first case. A 2-month-old infant presents with episodes of cyanosis that worsen with crying. Physical exam reveals a harsh systolic murmur at the left sternal border. Which anatomical components constitute Tetralogy of Fallot? Is it A. Ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, overriding aorta? B. Atrial septal defect, pulmonary stenosis, right atrial enlargement, overriding aorta? C. Ventricular septal defect, aortic stenosis, right ventricular hypertrophy, right-sided aortic arch? Or D. Patent ductus arteriosus, pulmonary stenosis, left ventricular hypertrophy, overriding pulmonary artery? The correct answer is A. Tetralogy of Fallot consists of 4 classic components: a ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. The ventricular septal defect is typically large and subaortic in position. The pulmonary stenosis can occur at multiple levels: valvular, infundibular, or both. Right ventricular hypertrophy develops as a response to the outflow tract obstruction. The overriding aorta occurs because the infundibular septum is anteriorly deviated. These defects all stem from a single embryological abnormality: anterior encephalad deviation of the infundibular septum. This anatomical comparison shows the structural differences between a normal heart and one with Tetralogy of Fallot. Note how the single embryological defect, the anterocephalad deviation of the infundibular septum, results in all 4 components. The severity of pulmonary stenosis largely determines the clinical presentation. With severe stenosis, more deoxygenated blood shunts right to left across the VSD, resulting in cyanosis. With milder stenosis, patients may be acyanotic initially. The degree of right ventricular hypertrophy develops proportionally to the severity and duration of the pulmonary outflow obstruction. Understanding this anatomy is crucial for clinical assessment and surgical planning. Let's consider our second case. A 6-month-old boy presents with bluish discoloration of lips and fingertips. His mother reports episodes of irritability with increased blueness, relieved when he squats. Physical exam shows clubbing and a harsh systolic murmur. Which physical finding is most specific to Tetralogy of Fallot? Is it A. Continuous machinery murmur at upper left sternal border, B. Hypercyanotic spells with squatting behavior, C. Split S2 with fixed splitting, or D. Diastolic rumble at the apex? The correct answer is B. Hypercyanotic spells with squatting behavior is the most specific finding for Tetralogy of Fallot. These TET spells occur when pulmonary blood flow decreases suddenly, causing acute worsening of cyanosis, irritability, and distress. Squatting increases systemic vascular resistance, which reduces right-to-left shunting across the VSD and improves pulmonary blood flow. This posture is instinctively adopted by toddlers with TOF, but is obviously not seen in very young infants. Other clinical findings may include clubbing, plethoric face, and conjunctival injection. The characteristic murmur is an ejection systolic murmur heard best at the left upper sternal border, representing turbulence across the pulmonary outflow tract. This algorithm outlines the management of hypercyanotic spells, which are medical emergencies. Initial measures include positioning, knee-chest position for infants, or squatting for older children, to increase systemic vascular resistance. Supplemental oxygen helps decrease respiratory distress and metabolic demands. Intravenous hydration is crucial as dehydration can trigger or worsen spells. Morphine reduces the infundibular spasm and provides sedation. Beta blockers like propranolol help relax infundibular muscle. Metabolic acidosis should be corrected with sodium bicarbonate. If these measures fail, vasopressors like phenylephrine or norepinephrine can increase systemic vascular resistance. In severe cases, emergency interventions may include packed red blood cells, intubation, and emergency surgical creation of a Blalock-Taussig shunt. Our third case involves a 4-month-old with suspected TOF undergoing evaluation. Vitals show heart rate 160, respiratory rate 50, oxygen saturation 85%. Examination reveals central cyanosis, clubbing, and a systolic murmur. Which chest X-ray finding is characteristic of Tetralogy of Fallot? Is it A. Increased pulmonary vascular markings, B. left atrial enlargement. C. Boot-shaped cardiac silhouette with pulmonary allogemia. Or D. Egg-on-side appearance with pulmonary congestion? The correct answer is C. The classic chest X-ray appearance in Tetralogy of Fallot is a boot-shaped cardiac silhouette with pulmonary allogemia. The boot shape, sometimes called Kerr and Sabot, results from right ventricular hypertrophy causing uplifting of the cardiac apex and a concave main pulmonary artery segment. Pulmonary allogemia reflects decreased pulmonary blood flow due to pulmonary stenosis. This contrasts with increased pulmonary vascular markings seen in left to right shunts. Other diagnostic findings include ECG changes such as right axis deviation, right ventricular hypertrophy, and tall P waves. Echocardiography is diagnostic, showing all four components of TOF, and is the imaging modality of choice for definitive diagnosis. This table compares the different diagnostic modalities used in evaluating Tetralogy of Fallot. ECG typically shows right axis deviation, right ventricular hypertrophy, and tall P waves reflecting right atrial enlargement. Chest X-ray demonstrates the classic boot-shaped heart with decreased pulmonary vascular markings. Echocardiography is the diagnostic gold standard, visualizing all four components and measuring pressure gradients across the pulmonary outflow tract. Cardiac MRI provides detailed anatomical information useful for surgical planning, particularly regarding pulmonary artery anatomy and aortopulmonary collaterals. Cardiac catheterization is less commonly performed for diagnosis, but may be needed to evaluate complex coronary anatomy or aortopulmonary collaterals before surgery. Laboratory studies may show polycythemia with hematocrit values potentially exceeding 60%, and ABGs often reveal metabolic acidosis. Our fourth case involves a 9-month-old with severe TOF presenting with oxygen saturations of 70 to 75%, increasing cyanotic spells, and failure to thrive despite medical management. What is the definitive surgical repair for this patient? Is it A. Pulmonary valvotomy alone, B. Blalock-Taussig shunt as definitive repair, C. Complete repair with VSD closure and relief of right ventricular outflow tract obstruction, or D. Fontan procedure? The correct answer is C. The definitive surgical treatment for Tetralogy of Fallot is complete repair with VSD closure and relief of right ventricular outflow tract obstruction. This addresses all anatomical defects and restores normal circulation. The repair typically includes patch closure of the VSD, resection of infundibular muscle bundles causing obstruction, and often a patch across the pulmonary valve annulus and proximal pulmonary artery. The timing of complete repair depends on institutional preference, anatomical factors, and symptoms, but is typically performed between 3 and 6 months of age or earlier if the infant is symptomatic. Pulmonary valvotomy alone would be insufficient as it addresses only one component of TOF. The Blalock-Taussig shunt is a palliative procedure sometimes used in very small infants or complex anatomy to increase pulmonary blood flow temporarily until complete repair. The Fontan procedure is used for single ventricle physiology, not for TOF. This table compares different surgical approaches for Tetralogy of Fallot. The complete primary repair approach, typically performed between 3 and 6 months of age, has the advantage of early normalization of physiology and prevention of right ventricular hypertrophy progression. The two-stage approach with an initial Blalock-Taussig shunt may be considered for very small infants, those with unfavorable pulmonary artery anatomy, or coronary anomalies crossing the right ventricular outflow tract. Regarding surgical techniques, the transatrial transpulmonary approach minimizes ventriculotomy and potential late arrhythmias, while the traditional transventricular approach may provide better exposure. When possible, valve-sparing techniques are preferred to preserve pulmonary valve function, but many patients require a transannular patch, which inevitably leads to pulmonary regurgitation. Long-term outcomes are generally excellent, though reoperations may be needed for pulmonary valve replacement in adulthood. For our fifth case, a 1-year-old with known TOF awaiting surgery presents to the emergency room with sudden onset of irritability, deep cyanosis, and hyperpnea following a febrile illness. What is the initial management step for this hypercyanotic spell? Is it A. Immediate cardiac catheterization, B. Knee-chest positioning and oxygen administration, C. Emergent intubation and mechanical ventilation, or D. Immediate cardioversion? The correct answer is B. The initial management step for a hypercyanotic spell is knee-chest positioning and oxygen administration. This positioning increases systemic vascular resistance, which decreases right-to-left shunting across the VSD and improves pulmonary blood flow. Supplemental oxygen helps decrease pulmonary vascular resistance and provides symptomatic relief. Additional management steps include intravenous fluid administration to ensure adequate hydration, morphine to reduce infundibular spasm and provide sedation, beta blockers like propranolol to relax right ventricular outflow tract obstruction, and sodium bicarbonate to correct metabolic acidosis. In severe cases not responding to these measures, phenylephrine may be used to increase systemic vascular resistance further, and some patients may require intubation and emergency surgery for a Blalock-Taussig shot. Immediate cardiac catheterization or cardioversion are not indicated for managing hypercyanotic spells. This algorithm outlines the step-by-step management of hypercyanotic spells in Tetralogy of Fallot. First-line measures include knee-chest positioning or squatting, 100% oxygen, intravenous fluid administration, and maintaining a calm environment. If these are insufficient, second-line interventions include morphine at 0.1 to 0.2 milligrams per kilogram to reduce infundibular spasm, propranolol to relax right ventricular outflow tract obstruction, and sodium bicarbonate to correct metabolic acidosis. Third-line measures for refractory cases include phenylephrine or norepinephrine to increase systemic vascular resistance and packed red blood cells if severe anemia is contributing. Fourth-line interventions include intubation and emergency surgical creation of a systemic to pulmonary shot. Prevention strategies include prophylactic beta blockers, avoiding dehydration, and prompt treatment of infections that might trigger spells. Let's examine our sixth case. A 16-year-old who underwent complete TOF repair at 6 months of age presents with decreased exercise tolerance, palpitations, and fatigue. ECG shows right bundle branch block and premature ventricular contractions, which is the most common long-term complication after TOF repair contributing to these symptoms. Is it A. Recurrent ventricular septal defect, B. Pulmonary regurgitation, C. Aortic stenosis, or D. Mitral valve prolapse? The correct answer is B. Pulmonary regurgitation is the most common long-term complication after Tetralogy of Fallot repair. This occurs primarily in patients who received a transannular patch, which disrupts pulmonary valve integrity. Over time, chronic pulmonary regurgitation leads to right ventricular dilation and dysfunction, resulting in symptoms of decreased exercise tolerance, fatigue, and arrhythmias. While recurrent ventricular septal defect can occur, it is less common. Aortic stenosis and mitral valve prolapse are not typical complications of TOF repair. The right ventricular volume overload from pulmonary regurgitation is progressive and eventually leads to right ventricular failure if not addressed. Pulmonary valve replacement is often required in adolescence or early adulthood. The timing depends on symptoms, exercise capacity, right ventricular size and function, and the presence of arrhythmias. This table outlines the comprehensive long-term follow-up required for patients after Tetralogy of Fallot repair. Regular cardiology follow-up should include electrocardiograms, echocardiography, and exercise testing to monitor for deterioration in functional capacity. Cardiac MRI is recommended every 2 to 3 years to accurately assess right ventricular size and function and quantify pulmonary regurgitation. Arrhythmia surveillance with Holter monitoring is important as ventricular arrhythmias can occur and may be associated with risk of sudden cardiac death. Indications for pulmonary valve replacement include severe pulmonary regurgitation with right ventricular dilation, decreased exercise capacity, and arrhythmias. Other potential long-term issues include aortic root dilation requiring monitoring, residual right ventricular outflow tract obstruction, and branch pulmonary stenosis. Lifelong specialized follow-up in adult congenital heart disease clinics is recommended for these patients. For our seventh case, during genetic evaluation of a newborn with TOF, the pediatrician notes dysmorphic facial features, thymic hypoplasia, hypocalcemia, and immune deficiency. Which genetic syndrome is most likely associated with this presentation? Is it A. Down syndrome, B. Williams syndrome, C. 20q11.2 deletion syndrome, also known as DeGeorge syndrome, or D. Turner syndrome? The correct answer is C. 22q11.2 deletion syndrome, also known as DeGeorge syndrome, is most likely associated with this presentation. This syndrome classically presents with cardiac defects, thymic hypoplasia leading to immune deficiency, parathyroid hypoplasia causing hypocalcemia, and characteristic facial dysmorphism. Tetralogy of Fallot is one of the most common cardiac defects seen in this syndrome, particularly TOF with pulmonary atresia and major aortopulmonary collateral arteries. While Down syndrome can also be associated with TOF, the combination of thymic hypoplasia and hypocalcemia strongly suggests DeGeorge syndrome. Approximately 15% of patients with TOF have 22q11.2 deletion. Recognition of this association is crucial as these patients require multidisciplinary management, including immunology evaluation, calcium monitoring, developmental assessment, and specialty follow-up beyond cardiac care. This table compares different genetic syndromes associated with Tetralogy of Fallot. 22q11.2 deletion syndrome accounts for 15 to 20% of TOF cases and features immune deficiency, hypocalcemia, and characteristic facial features, including hypertelorism, micronathia, and low-set ears. Down syndrome is associated with 5 to 8% of TOF cases and presents with intellectual disability, characteristic facial features, and often endocardial cushion defects in addition to TOF. Charge syndrome includes coloboma, heart defects including TOF, choanal atresia, growth retardation, genital abnormalities, and ear anomalies. Alagille syndrome may present with TOF or peripheral pulmonary stenosis along with bile duct paucity and characteristic facies. Vectoral association includes vertebral, anorectal, cardiac including TOF, tracheoesophageal, renal, and limb anomalies. Genetic testing is recommended for all TOF patients as identification of underlying syndromes has important implications for comprehensive management. Our 8th case involves a 3-month-old with TOF who has moderate cyanosis with oxygen saturations 80 to 85%, but is feeding well and gaining weight. Surgery is planned at 6 months. What is the most appropriate preoperative management for this infant? Is it A. Immediate surgical repair regardless of clinical status, B. Prophylactic beta blockers and close monitoring, C. Palliative Blalock-Taussig shunt now, complete repair later, or D. Home oxygen therapy and monthly echocardiography? The correct answer is B. Prophylactic beta blockers and close monitoring is the most appropriate management for this stable infant with Tetralogy of Fallot. The child has moderate cyanosis but is thriving, suggesting adequate pulmonary blood flow for current growth needs. Beta blockers like propranolol can reduce infundibular spasm and prevent hypercyanotic spells while awaiting definitive repair. The current practice at most centers is to perform complete primary repair at 4 to 6 months of age in stable patients. Immediate surgical repair is not necessary for clinically stable patients with adequate growth. A palliative Blalock-Taussig shunt would be considered only if the infant develops worsening cyanosis, hypercyanotic spells unresponsive to medical therapy, or failure to thrive. Home oxygen therapy has limited benefit in TOF as the hypoxemia results from right-to-left shunting rather than primary lung disease. This flowchart outlines the decision-making process for managing patients with Tetralogy of Fallot awaiting surgical repair. Assessment parameters include oxygen saturation trends, growth velocity, developmental progress, and the presence and frequency of hypercyanotic spells. For stable patients like our case, beta blockers and regular monitoring represent the standard of care. Propranolol is typically dosed at 0.5 to 1 mg per kilogram every 6 hours. Regular follow-up should occur every 1 to 2 months with weight checks, oxygen saturation monitoring, and developmental assessment. Indications for earlier intervention include hypercyanotic spells despite medication, failure to thrive, or progressive cyanosis with saturations consistently below 75 to 80%. Parent education is crucial, including recognition of hypercyanotic spells, proper knee-chest positioning technique, and clear guidelines on when to seek emergency care. For our 9th case, a 2-month-old with Down syndrome has a heart murmur. Echocardiography shows a large VSD, pulmonary stenosis, right ventricular hypertrophy, and overriding aorta. What special consideration is important in the management of Tetralogy of Fallot in patients with Down syndrome? Is it A. They typically have milder forms of TOF requiring no intervention. B. They have higher perioperative mortality. C. They require earlier intervention due to faster progression. Or D. They have higher rates of associated complete AV canal defects? The correct answer is D. Patients with Down syndrome and Tetralogy of Fallot have higher rates of associated complete atrioventricular canal defects, sometimes called AVSD plus TOF. This combination requires a more complex surgical approach than isolated TOF, as both the septal defects and the right ventricular outflow tract obstruction must be addressed. While patients with Down syndrome may have higher perioperative risks, this is primarily due to associated comorbidities rather than intrinsically higher mortality from TOF itself. They don't typically require earlier intervention due to faster progression, as the TOF progression is similar to non-syndromic cases. However, these patients often present with additional considerations, including respiratory complications due to airway hypotonia, higher infection risk, and they are frequently small for age with feeding difficulties that may complicate perioperative care. This table compares management considerations for tetralogy of Fallot in different syndromic contexts. In Down syndrome, key considerations include the higher prevalence of atrioventricular canal defects requiring more complex repair, respiratory complications due to airway hypotonia, and higher infection risk requiring vigilant postoperative care. Patients with 22q11.2 deletion syndrome require immune evaluation before surgery, calcium monitoring, and often have more complex pulmonary artery anatomy, including discontinuous pulmonary arteries and major aortopulmonary collaterals. Charge syndrome presents additional challenges with airway issues, feeding difficulties, and multi-system involvement requiring extensive pre-surgical evaluation. For all syndromic patients, comprehensive pre-surgical assessment should include evaluation of all affected systems, genetic counseling, and planning for potential postoperative complications. Postoperative care must be tailored to address syndrome-specific vulnerabilities, and long-term follow-up should involve multiple specialties beyond cardiology. Our 10th case involves a 30-year-old man who had TOF repair at age for presenting with palpitations and syncope. ECG shows ventricular tachycardia. Cardiac MRI reveals severe right ventricular dilation and dysfunction with pulmonary regurgitation. What is the most appropriate next step in management? Is it A. Antiarrhythmic medication only, B. Pulmonary valve replacement, C. Cardiac transplantation, or D. Radiofrequency ablation of arrhythmogenic foci? The correct answer is B. Pulmonary valve replacement is the most appropriate next step in management. This patient has severe right ventricular dilation and dysfunction resulting from chronic pulmonary regurgitation, which is the underlying cause of his ventricular arrhythmias. Addressing the hemodynamic problem with pulmonary valve replacement can reduce arrhythmia burden by reducing right ventricular size and improving function. Antiarrhythmic medication alone would not address the underlying hemodynamic issue and has limited long-term efficacy. Cardiac transplantation would be excessive at this stage as pulmonary valve replacement can significantly improve ventricular function. Radiofrequency ablation might be considered as an adjunctive therapy but would not address the underlying cause. During pulmonary valve replacement surgery, intraoperative mapping and cryoablation of arrhythmogenic foci may also be performed. This algorithm outlines the comprehensive approach to adult patients with repaired tetralogy of Fallot. Assessment should include evaluation of symptoms, ECG, echocardiography, exercise testing, cardiac MRI for accurate right ventricular volumes, and Holter monitoring for arrhythmia detection. Indications for pulmonary valve replacement include right ventricular end-diastolic volume greater than 150 to 170 milliliters per square meter, right ventricle to left ventricle ratio exceeding 2.0, decreased exercise capacity, and arrhythmias. Risk stratification for sudden cardiac death considers factors such as QRS duration greater than 180 milliseconds, significant ventricular dysfunction, and history of ventricular arrhythmias. Valve options include bioprosthetic valves, which are most commonly used, mechanical valves requiring lifelong anticoagulation, and transcatheter pulmonary valve implantation in suitable candidates. Our 11th case involves a 26-year-old woman with repaired TOF who wishes to become pregnant. She is asymptomatic with mild pulmonary regurgitation, preserved right ventricular function, and no arrhythmias. What is the appropriate preconception counseling regarding pregnancy risk? Is it A. Pregnancy is absolutely contraindicated due to high maternal mortality. B. Pregnancy carries minimal increased risk with close monitoring. C. Pregnancy requires pulmonary valve replacement before conception regardless of cardiac status. Or D. Pregnancy necessitates termination of any prior cardiac medications? The correct answer is B. For this patient with well-repaired tetralogy of Fallot, minimal pulmonary regurgitation, preserved right ventricular function, and no arrhythmias, pregnancy carries minimal increased risk with close monitoring. Women with good functional status and preserved ventricular function typically tolerate pregnancy well. Pregnancy is not absolutely contraindicated in repaired TOF as stated in option A. That would be excessive for most patients. Option C is incorrect as pulmonary valve replacement before conception is only recommended for women with severe pulmonary regurgitation and significant right ventricular dilation or dysfunction. Option D is also incorrect as most cardiac medications should be evaluated individually. Some may need to be continued, adjusted, or switched to pregnancy-safe alternatives. This patient should receive multidisciplinary care from cardiology and high-risk obstetrics throughout pregnancy with regular monitoring of cardiac function. This table outlines risk assessment for pregnancy in women with repaired tetralogy of Fallot. Low-risk patients like our case have good functional class, minimal residual lesions, and preserved ventricular function. These women typically tolerate pregnancy well with quarterly cardiology assessments. Intermediate-risk patients have moderate pulmonary regurgitation with mild to moderate right ventricular enlargement or mild to moderate ventricular dysfunction. These women require more frequent monitoring, typically every 1 to 2 months. High-risk patients have severe pulmonary regurgitation with right ventricular dysfunction, significant right ventricular outflow tract obstruction, or significant arrhythmias. These women should consider pulmonary valve replacement before pregnancy and require monthly specialist monitoring if pregnancy occurs. For all risk categories, echocardiography should be performed at least once during pregnancy, with more frequent assessment in higher risk groups. Vaginal delivery is typically acceptable for most women with repaired TOF, with cesarean section reserved for obstetric indications. Our 12th case involves a newborn noted to have mild cyanosis with oxygen saturation 88 to 90% and a harsh systolic murmur. Echocardiography confirms TOF with moderate pulmonary stenosis. Which finding would indicate need for early intervention in this neonate? Is it A. Oxygen saturation of 88% at rest, B. Right ventricular hypertrophy on ECG, C. Ductal-dependent pulmonary blood flow, or D. Boot-shaped heart on chest X-ray? The correct answer is C. Ductal-dependent pulmonary blood flow would indicate the need for early intervention in this neonate. This finding suggests severe right ventricular outflow tract obstruction or functional pulmonary atresia, where pulmonary blood flow is critically dependent on the patent ductus arteriosus. Such patients require prostaglandin E1 infusion to maintain ductal patency until surgical intervention, which is typically an early systemic to pulmonary shunt followed by complete repair later. The other findings mentioned are expected in Tetralogy of Fallot and don't necessarily indicate need for urgent intervention. Oxygen saturation of 88% at rest represents mild cyanosis, which is typical and well tolerated. Right ventricular hypertrophy on ECG is an expected finding due to the right ventricular outflow tract obstruction. A boot-shaped heart on chest X-ray is the classic radiographic appearance of TOF and doesn't by itself indicate surgical urgency. This table outlines management approaches for neonates with Tetralogy of Fallot based on clinical presentation. Clinical scenarios requiring immediate intervention include ductal-dependent pulmonary blood flow, severe cyanosis with oxygen saturation below 70%, and hypercyanotic spells occurring in the neonatal period. Medical management in urgent cases includes prostaglandin E1 infusion at 0.05 to 0.1 micrograms per kilogram per minute to maintain ductal patency, cautious beta blocker use, and careful fluid management. Surgical options include a Blalock-Taussig shunt as a palliative procedure versus early complete repair, with the decision based on patient size, anatomy, and institutional experience. For non-urgent cases like our patient with mild cyanosis, monitoring parameters include oxygen saturation trends, weight gain, and development of hypercyanotic spells. As we conclude our comprehensive review of Tetralogy of Fallot, let's summarize the key points. Tetralogy of Fallot consists of 4 components: ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and overriding aorta, all stemming from anterocephalad deviation of the infundibular septum. Clinical presentation varies along a spectrum from pink tets, with minimal cyanosis to severely cyanotic infants, depending primarily on the degree of pulmonary stenosis. Management principles include appropriate medical stabilization, optimal surgical timing based on individual anatomy and symptoms, and structured long-term follow-up. Prompt recognition and proper management of hypercyanotic spells is crucial for preventing morbidity and mortality. Finally, lifelong surveillance is essential as these patients face potential late complications including pulmonary regurgitation, right ventricular dysfunction, arrhythmias, and exercise intolerance. With modern surgical techniques and comprehensive care, most patients with TOF can expect excellent quality of life and near normal life expectancy. Thank you for joining this comprehensive review of Tetralogy of Fallot in pediatric practice. We at Pediatric Case Review are committed to providing evidence-based, clinically relevant content for healthcare professionals. If you found this presentation valuable, please subscribe to our channel for more educational content on pediatric cardiology and other subspecialties. We encourage you to leave comments or questions below. Your feedback helps us improve future presentations. For further learning, consider exploring the additional resources linked in the description. Stay tuned for our upcoming lectures on other congenital heart defects and pediatric cardiology topics. This is Dr. Abdelaziz Yousef, and I look forward to seeing you in our next educational video.